Okay, moving on to my favorite of all time modalities, microcurrent. Probably Drew's favorite of all time right now. She was a hard one to convert, but I think she would tell you that it was a very, very effective in an acute situation. So the probes that you have seen before that had the cotton, basically we cut off the cotton tips of a Q-tip and put them in there, and they would make contact with the probes. These have already metal, and we just use basically ultrasound gel as a conductor. It's kind of nice that way, probably easier to clean, sterile, that type of thing. It doesn't have an activator on these probes, so there's not that button that you could, remotely go on and off. It doesn't have that. And it doesn't actually have a countdown here. So basically, once we set this up on the machine, you would just in your mind move 5, 6, 7 seconds. So the reason microcurrent is so effective that I believe, and also give you the reason why it's not used, is again, it's the same current as the body, and so the other waveforms are in milliamps, and that's why you get that sensation that can be uncomfortable at times. This is sub-sensational, so it's basically the same current as the body is carrying, and Lynn Wallace is the one that kind of developed this commercially, and then we proceed from there. But so we're typically going to be around 300 microamps, which is, it takes 1,000 microamps to make 1 milliamp. And so when you set up your TENS unit or IFC, whatever, that's 1 milliamp, and this is going to be basically a third of that, and they shouldn't feel a thing. And that maybe was one of the reasons it kind of went away, but more than likely the outcomes were excellent. It went away because it's very labor intensive. And back when we could do outpatient and you could make a living off 10 patients a day, then that was very effective. You could take the time and do this, and it was wonderful. And then it got to be big business and productivity change, and you had to see 15, 20. So you didn't have the time to invest on a patient using the probes. It's the probes by far. I've used it for my tooth. I've used it so many times in a situation where the pain level is at least an 8. And honestly, I'm amazed as much as anybody every time it works, because it just seems like such a dramatic change. But it does. I'd say it's 75, 80% effective the very first time to take a level that is an 8, 9, or 10 way down to a 1, 2. And that gets the patient on board. They're turned on about this, and they're going to be very, very compliant. And I just wish we could get back to it. But, again, these 2 probes are $500. And you attach that to the labor that it's going to take. You can see why facilities aren't going to do it. And most facilities haven't even upgraded their E-stem units. They don't see, again, the value of $4,000 investment when it's going to take that long based on reimbursement for each treatment to get the money back. And so I get it, but I'm not going to go away with it. I just think it's wonderful. So again, I'm going to just show you basically the 3 techniques. And the thing with this is that after you've done each time, each muscle, because you basically are going to separate out each muscle, you're kind of using it again diagnostically. So you're going to try to find the culprit, who's really causing the pain, who's really causing the dysfunction. So after each time you've gone through this pattern of the techniques, then you reassess. And then if that didn't do well, you go somewhere else, another muscle group, another muscle, do it again, reassess, until you all of a sudden you get that, there it is. It's immediate. So I'll have her switch over, and you can kind of see the screen on the little Theramini that we're using. And again, so it's set up, micro, you can see we're at 300, the cycle is 2.7 seconds. This thing is, micro can be basically considered direct current, but I don't even think you should just categorize it that. It's considered, a DC, but it really, because it's subsensational, and you're not going to have any problem with any kind of alkaline type of buildup. So let's just take a look. We're at the VMO again. I added a little bit here. I'll hit the start button. We're good to go. It's counting down. So EMR, and we have Golgi tendon, and then we have what they call swirl the dragon. So EMR basically is you're going to take, and you can see the fibers here, and it's like anything else. You've got two mobile electrodes, and the further apart you go or the closer together, it changes the depth. And so I'm going to go through this pattern about 5 seconds, and then we're going to move, and again, I don't feel a thing, and I'm going to break this up all the way through. You have a tendency to get kind of fast on it, but I have the sound off too. So then now I'm going to go more towards the middle fibers. I mean, there's a lot of incredibly great studies where within 3 to 5 treatments, the pain scales are almost always going down to 0. And so, if I'm choosing any modality for a patient that has an acute onset, then I am going to go right into microcurrent. It's a little harder for chronic problems, but again, it can be very useful to use the probes diagnostically to maybe you're not even in the right area. It wasn't even the area that they're complaining about. It could be referred pain, and so it might take a quarter or quadrant at a time until you maybe hit that home run, and all of a sudden they say, boom, it's gone, that type of thing. So that's EMR, and then you have the GTO, which basically is origin insertion. So you would go boom, boom. You wouldn't really say boom, but you could if you want to. So again, that's GTO, origin insertion, that type of thing. And we're not quite at the origin insertion, but so then the last one is kind of a swirl the dragon, they call it. You have one center point, and then you're going to go around it. Typically, like I said, 5-10 seconds at a time as you go around. I'll speed it up a little bit. And you can change, again, you can change so many different things. You can go closer, further away. I mean, you just have to be as creative as you can and be patient as you are there. The other machine, if we did the almost a trigger point, we had a fourth type of technique. That would be where we would listen to the pitch, and when the pitch got higher, it would mean there was less or more basically fluid in the area, edema, and so there's less resistance, and so you get a higher pitch, and then you could just focus in that area, and that's pretty effective. But you do know just from being around that pitch gets kind of annoying at times. You can turn it down or go to a private treatment room. So then I would reassess. And so whatever I'd have them do, whether I'm going to have it do a straight leg raise, I'm going to do some kind of any kind of quad set, anything that would, basically you could reproduce the pain to start the treatment. And then as you went through and did this type of treatment, you would reassess until, like I said, we'd go there. So it could be even deeper. We might have to go more middle fibers, that type of thing. But my favorite for sure. And when we do get back, and we'll have those times together in the summer, we'll hopefully have somebody that has a 10/10 pain. I know it's something you really don't want me to wish for, but it's very effective in a learning tool. So we got to use it with Drew, but she was unfortunately doing a lab practical, and only just got to see the miracle of the probe. So, all right, thank you.